Hello, my name is Scott Siegel, and I'm the Director of Cancer Control and Population Sciences at the Quality Center for Translational Cancer Research within the Helen F. Graham Cancer Center and Research Institute at Christiana Care. It is my pleasure and honor to be here for the 27th Annual Breast Cancer Update with the Delaware Breast Cancer Coalition as I present about our population health research on triple-negative breast cancer. Within this talk, I'm titling Reducing the Burden of Breast Cancer and Ending Disparities in Delaware with Precision Health. My talk will be in three parts. First, I will talk about breast cancer nationally, before talking about what's going on here in Delaware specifically, and then finally concluding with our Precision Health plan to both reduce the burden of breast cancer in the state and close disparities. So beginning first with the national picture. We know that breast cancer is the most common cancer in the United States. Over 300,000 new invasive cases will be diagnosed this year. 1 in 8 women will be diagnosed in their lifetimes. And while I'm sensitive to this is a difficult topic to talk about, it is important to acknowledge that breast cancer is also the second leading cause of cancer deaths. Over 42,000 women in our country will die from breast cancer this year, and 1 in 43 women will die from breast cancer. Now, what I'm showing you here, data from the American Cancer Society, is a figure of new cancer cases or incidence. And you can see that the top line represents breast cancer, and it is much higher on the figure than all the other leading causes of cancer. So that just illustrates how much more common breast cancer is than other cancers. If you're wondering what the little dots are below the lines, that just represents the number of new cases in the year 2020, when the COVID-19 epidemic was starting. And our expected numbers of new cases were disrupted by challenges in getting people into healthcare for screening and diagnostic purposes. What we're seeing that year set aside is that there's been a slight increase in new cases of breast cancer over the last 10 or so years. But this is not necessarily cause for concern because most of this has been driven by improved early detection of local stage disease, which this figure more clearly shows. You can see that the increases since 1998 or so have been in the local stage of disease, whereas regional and distant stages of diseases have been largely flat. The good news is that there's been more than a 40% decrease in breast cancer deaths over the last 50 years. I think it's important to just take a moment to acknowledge and even celebrate this fact. It's not something that maybe we talk about enough. We talk about the concerns and the worries as we have good reason to do so. But I also just want to underscore, especially now, that these decreases are the result of improvements in screening and other forms of prevention, treatment that have only been made possible by funding our National Institutes of Health, specifically the National Cancer Institute and other agencies tasked with improving the state of care for breast cancer. So in order to continue to have success, we need to continue that work. That being said, not all groups have benefited equally from those advancements. In particular, as this graph shows breast cancer mortality rates broken down by racial and ethnic group, Black women in particular are 40% more likely to die from breast cancer than white women and women from other groups. And if you look at younger women, women under age 50, younger Black women are actually twice as likely to die from breast cancer as other groups. So what causes this disparity? If you look back over time, you can see there actually didn't used to be a disparity. If you go back as far as the early 1980s, and what happened at that point were two new really important medical innovations that were widely disseminated. The first being screening mammography, and the second being hormone therapy, really the first targeted therapy for breast cancer in the form of tamoxifen. We now have a whole class of hormone therapy medications, but it started with tamoxifen. So let me talk to you in a little more detail about each of these medical innovations and why it may have not benefited all groups equitably, resulting in the current disparity and what really amounts to a 20-year gap in progress in terms of reducing breast cancer mortality for Black women relative to other groups. So the first medical advancement I mentioned is screening mammography. And what we know is that Regular screening is associated with much earlier stage at detection or at diagnosis and improved treatment outcomes. Black women, though, we know, face structural barriers to accessing screening mammography and as a result are 20% less likely to complete their screening as recommended. And what this means is less screening, more advanced breast cancer. 4 in 10 black women are diagnosed with breast cancer at an advanced stage. Or I should say more accurately, 4 in 10 black women with breast cancer are diagnosed at an advanced stage versus 3 in 10 white women. Now moving on to the second medical advancement, I mentioned hormone therapy. This illustration shows you what we would call is a hormone receptor positive tumor, which is in this case expressing estrogen receptors. When activated by estrogen, that stimulates the tumor to grow. What tamoxifen does is it basically fills in those receptors and it stops the estrogen from activating it. Now, about 70 to 80% of breast cancer tumors are hormone receptor positive, and when taken as recommended, hormone therapy can reduce the risk of recurrence by 50% for hormone receptor positive tumors. However, not all breast cancer tumors are hormone receptor positive, and one subtype called triple negative breast cancer is an important one to focus on. It represents about 15% of breast cancer tumors, and by definition, because it lacks estrogen and progesterone receptors, triple negative breast cancer does not respond to hormone therapy. Triple negative breast cancer is also the most aggressive subtype of breast cancer. It tends to present at a younger age and grow more quickly and therefore show up at a more advanced stage. And as this graph shows, black women are twice as likely to be diagnosed with triple negative breast cancer as white women. And this one subtype, as a result of it being more prevalent among black women, more aggressive, less likely to respond to treatments, it accounts for more than half of the overall black-white disparity in breast cancer mortality. I'm showing that same fact here with these two figures. The donut chart on the right shows you that triple negative breast cancer, the red section, it makes up about 15% of all breast cancer tumors, so a relatively small number. But if you look at the donut figure on the left, you can see that actually triple negative breast cancer by itself accounts for 56% of that black-white difference in breast cancer mortality. So this subtype, while small in size in terms of incidence, makes an outsized impact on breast cancer mortality. So it's of concern for us. So just to summarize everything I shared with you about the national data, breast cancer continues to be the most common cause of cancer. We have seen a small increase in incidence over the last decade, but that's mostly attributable to improved early detection. Deaths from breast cancer mortality have decreased by more than 40% over the last 50 years. But black women have not benefited equitably, which can be attributed to reduced access to mammography and a higher incidence of triple negative breast cancer. So now let's turn to what's going on here in Delaware specifically. So as it turns out, Delaware is number 1 in the United States for late-stage breast cancer among younger women or women under 50. And in our own research, with that fact in mind, we've used geospatial analytics to really identify where are those advanced breast cancer cases. And you can see here in that red circle, what corresponds to Northeast Wilmington, also known as the Riverside community, is a hot spot for advanced breast cancer cases. And consistent with everything I shared with you about screening, what we learned is that less than a third of the advanced breast cancer cases in that community were detected with screening. So just to put this even more into context, I mentioned earlier that 4 in 10 black women, 40%, are diagnosed at an advanced stage nationally. 30% of white women are diagnosed at an advanced stage nationally. The women in this hotspot, 55%, are being diagnosed with an advanced stage breast cancer, and less than a third of them were detected through screening, meaning it was detected either by the patient themselves, may have detected a lump or some other symptom, or a provider on exam. Now, if you look at this figure, this is looking at advanced breast cancer among women under 50, and you can see that there's this hot spot in the southern part of the county, and that corresponds to Middletown. And What I'm not showing in this figure, but what we also found, was a larger area encompassing that hotspot and going further outside the borders of Middletown, where we see a higher rate of all breast cancer for women under age 50, regardless of stage. But then within Middletown proper, we're seeing this hotspot for both advanced and under age 50. Now, in addition to being number one for late stage breast cancer among younger women, Delaware is also number one in the United States for triple negative breast cancer. That's true for overall triple negative breast cancer incidence and also the incidence specifically among Black women. When it comes to white women, Delaware has a higher than average rate of triple negative breast cancer incidence, but it's nowhere near number one, which then therefore contributes to us being number one for the Black-white disparity in triple negative breast cancer incidence, meaning if you look at the ratio of Black women to white women for incidence of triple negative breast cancer, that ratio is larger in Delaware than for any other state in the United States. And again, we use geospatial analytics to look at where the cases are. We found two hotspots, one in eastern Wilmington and another one in the Bear, Newcastle area. So to summarize the findings from others' reports in our own research, we can say that Delaware leads the U.S. in late-stage breast cancer among younger women. Hotspots identified in Wilmington and Middletown. Delaware also leads the U.S. in triple-negative breast cancer incidence. Hotspots identified in Wilmington and Bear, Newcastle. And therefore, taken together, Delaware really leads the U.S. for the two factors that I previously described as driving disparities: suboptimal early detection, particularly among younger women, and more aggressive tumor biology in the form of the highest triple-negative breast cancer incidence. So with all those concerning statistics in mind, what are we doing about it? In this last section, I'm going to speak to you about our precision health plan to both reduce the burden of breast cancer and drive down disparities in our own state. Before getting into that, I just want to share with you this framework, and some of you may have seen some version of this illustration before. I like this particular version because it includes reality, equality, equity, and justice, and it also shows fans watching a soccer game, and I'm a big soccer fan. So on the left-hand side, you can see reality. Some people are just advantaged relative to others, and some people are disadvantaged. You can see the first individual is standing on 4 boxes and can very easily see the game. The second individual is standing on 1 box and can see the game fine. The third person is actually in a hole and has no chance of seeing the game. Equality means giving everybody the same thing. Everybody gets 1 box. Now, for the first 2 individuals, that's sufficient. For the third individual, it's not enough, and they're not able to see the game. Equity is different. It's not about giving everybody the same thing. It's giving people what they need so that they can achieve the same outcome. So the first individual doesn't need a box. The second individual needs 1 box. The third individual, 2 boxes. When they all get what they need, they can all see the game. And then justice means removing barriers altogether so that regardless of anyone's position, they're able to get the same outcome without any additional intervention. So as applies to breast cancer, the reality, as I've described, is that medical advancements have not produced similar gains across all groups. Some groups are more advantaged relative to others. Equality, which would mean giving everybody exactly the same thing, would still produce disparities because the different group risk profiles. So even if we equalized access to screening mammography, which we should do, that may not be enough to overcome the other issues, such as the higher triple-negative breast cancer incidence that we've been describing. Equity, providing everybody what they need to achieve the same outcome, we believe we now have the tools to do so and address the unique needs of each group, which I'll get into in just a moment. Now, of course, justice would be our long-term aspiration, where one's race or the neighborhood where they reside does not increase their risk. We're not there yet, but we believe we can achieve those outcomes through our equity approach. So we believe the future is in precision health. Precision health refers to a collection of approaches that first began with precision medicine, which was first passed into law by the Obama administration. And it entails personalizing care to the individual genetic alterations and other unique clinical characteristics for that patient. So long gone now are the days of one-size-fits-all treatments. We are very much in the realm of the precision medicine world, where treatments are tailored based not just on the tumor subtype and the receptors that are being expressed, but these genetic alterations as well. And it produces much better outcomes. But it's also important to know that most genetic alterations are actually not inherited, but instead are the result of damage incurred from environmental and behavioral exposures over one's lifetime. So the air that we breathe, the water that we drink, the food that we eat, the exercise that we do or do not engage in, the sunlight that we're exposed to, smoking, alcohol, all the other types of exposures that we know are associated with increased risk of cancer can produce genetic damage. And if we're going to develop treatments based off of environmental and behavioral contributors to genetic alterations and breast cancer outcomes, we need to really consider a new approach called precision public health. And that's an emerging field that draws on and complements precision medicine to address those behavioral and environmental influences on illness. This is, on the right-hand side, is a commentary in the Delaware Journal of Public Health that we published last year that goes into much more detail on this. If anybody is interested in reading it, it is open access. And I like this one line from this commentary where we say, precision public health personalizes prevention to the context of disease, meaning where people live and the behaviors that they engage in. So what does that look like in practice? So I'm going to take you back to the one hotspot that I previously showed you in the northeast part of Wilmington. And you can see in the inset map on the right-hand side, it's just a blown up version of that Wilmington area. And that red circle is that advanced breast cancer hotspot that I showed you before, where we see about 55% of breast cancer cases being diagnosed at an advanced stage. You can see that that red circle lies at the intersection of two other hotspots. The green turquoise half circle area is the triple negative breast cancer hotspot that I also showed you previously for the eastern part of Wilmington. And what's new here is that more orange oblong shaped area. And that represents an area where we see a higher percentage of women who are not current on breast cancer screening as recommended. So lower rates of screening in that area. And you can see that the advanced breast cancer hotspot really is at the area where you see both lower rates of screening and higher rates of more aggressive forms of breast cancer. And it's those two factors that really seem to drive the stage of diagnosis. Screening more regularly, you're more likely to detect breast cancer at an earlier stage, but not absolutely, because even for women who are screened every year, if you have a more aggressive form of breast cancer, it may grow in that interval between screenings. But what we're finding is the greatest risk of advanced breast cancer is where you have both in combination. Less screening, more aggressive breast cancer. So what are we doing about that? So in that hotspot, we're embedding a community health worker. Now, community health workers are lay members of the public who come from the community that they serve. They understand the way of life in a given community. They understand its culture. They understand how to build trust and rapport, and they can serve as a liaison to the healthcare system. There's been a lot of research to show that community health workers can improve prevention across a whole range of medical areas, including breast cancer screening. So our hope is that this person, by virtue of, again, being able to establish trust and serve as a liaison to the health system, can provide information and education on the importance of breast cancer screening, particularly in this community, address any barriers that may be stopping someone from getting screening. That could be anything from insurance or just not knowing where to go or having issues with transportation or childcare. And we're partnering with our community-based organization in that community called Reach Riverside, who can help address some of those social determinants of health in partnership with us as the health system to ensure that women are getting screened. In addition, why are we seeing higher rates of triple-negative breast cancer in this community? There's a couple of factors going on, we believe. One is there's a much higher rate of family history in this area. We saw anywhere between a third, upwards of 40% of women who were diagnosed with breast cancer actually had a pretty significant family history that went undocumented prior to their diagnosis. So we're hoping that our community health worker will also be able to administer validated breast cancer risk assessments that will collect information on family history, as well as a range of other risk factors known to put women at greater risk for breast cancer. For women who are found to be at above average risk, then we can route them to a high-risk breast cancer prevention pathway. That might mean starting screening at a younger age, which is important because, as I mentioned, triple-negative breast cancer can sometimes present before age 40 or when women begin screening. It may involve supplemental forms of screening. It may involve even prophylactic treatments where indicated. But the important thing is if a woman has risk factors for breast cancer and they don't get documented until the time of diagnosis, that's not really helping. So we need to get ahead of this and administer these risk assessments to women before screening age, ideally in their 20s and 30s, so that we have time to act on it. So the community health worker really has a dual purpose. One, increase the uptake of screening in this community where we know there's a big opportunity to do so. And two, begin to assess risk and get women who are at above average risk onto these high-risk pathways. So going forward, what do we want to do? Well, the program in the Riverside community is a pilot. We hope to learn from that. We hope we're successful. If not, we'll make adjustments. But the ultimate goal is really to scale that precision health approach statewide. And we're doing all this work in partnership with the Delaware Cancer Consortium and the state who supported this pilot. And as we look to scale statewide, we will partner with other health systems and community groups and organizations. And in order to guide that work, to know where to focus, we are actually now currently analyzing data from the Delaware Cancer Registry. So all of the breast cancer cases for all of Delaware, not just what's happening in Newcastle County. And we're hoping to identify high priority communities in Kent and Sussex counties and potentially hotspots. We just started this work, it's ongoing, but the preliminary evidence is already pointing to those opportunities in the Kent and Sussex area. So stay tuned. I hope to have findings that we can share either later this year or early next year. And then I just wanted to, before I wrapped up for today, touch on a couple other things that I didn't really have the time to delve into, but are important going forward in our efforts to reduce the burden of breast cancer and close disparities. The first is the translational cancer research that we conduct at the Helen Graham Center. And translational research really refers to research that is about taking what we're learning from basic research and seeing can we apply it to either improve prevention or treatment. And one of the areas that we're very concerned about is early detection, as I mentioned, and particularly for aggressive cancers that may present before screening age. And so just like we have blood-based biomarker of risk tests, like a cholesterol test to say you are at greater risk of heart disease, we're hoping to develop such a test for breast cancer. So a biomarker of risk means we can measure this, and by virtue of you having it, it tells us that you're at greater risk and that we should put some additional prevention measures in place. Epigenetic, for those of you who have not heard the term before, just refers to how environmental and behavioral factors influence which genes are turned on or off or in some other way modified. And as I mentioned earlier, those genetic alterations are largely, the genetic alterations implicated in cancer are largely the result of those behavioral and environmental exposures. So epigenetics is really the field of measuring how those exposures change gene expression. So this is work I'm doing with my collaborator at the Cancer Center, Dr. Jennifer Sims-Mortada. We have some preliminary evidence to show that in hotspots, we are seeing different biomarker measures. And this has got a longer runway before we can bring this to the field, but we are getting encouraging preliminary findings, and this is work that's in progress. Again, I couldn't really get into this in detail today, but for those who are interested in this or are partnering in some way, please do reach out. And then finally, everything I've really talked about today has been about prevention. And that's for good reason, because between 2/3 and 3/4 of the disparities that we see are really attributable to factors that were present at the time of diagnosis or from before. Meaning the greatest opportunity to reduce disparities is by addressing prevention. But still, that leaves somewhere between a quarter and a third of the factors that are due to treatment. So we do have ongoing work around time from screen to diagnosis and then on to treatment, because we know that any delays can be consequential. And then finally, we are doing work on adherence to adjuvant endocrine therapy. Now, I've been talking to you a lot about triple negative breast cancer, where endocrine or hormone therapy is really not indicated. But for the 70+% of breast cancer tumors that are hormone receptor positive, taking endocrine therapy is really important. And like I said, it can reduce the risk of recurrence by 50%. But it also, being on those therapies, can produce a lot of side effects, and it can make it difficult to stay on the treatment, to adhere to it as recommended. So we have ongoing research as well to hopefully intervene and improve those side effects to make it more possible to stay on those drugs long term. So again, if any of this is of interest to you, you're doing work in this, or you want to partner in some way, please feel free to either in the Q&A ask a question, make a comment, or my contact information will be made available. Please feel free to follow up with me after today's talk. The very last thing I want to say before turning it over to Q&A is that all of our work is very focused on the community we serve here in Delaware. But even though we're a small state, we are mighty in terms of the impact we're even making on a national scene. What I'm showing you here on the left is the updated screening recommendations from the U.S. Preventative Services Task Force that last year formalized the recommendation that women of average risk should begin screening at age 40, down from age 50. And this really brought the USPSTF into line with several other medical organizations in terms of the recommendations, but this one is particularly important because this is the one that determines reimbursement. And this was widely celebrated in the breast cancer advocacy world. I just want to point out on the right-hand side that highlighted text, which may be too small for you to read right now, but they did cite in a small way, as part of their rationale for making this change, research that we did here in Delaware. Colleagues of mine that I conducted a few years ago is referenced below. So I just wanted to say that while our focus is on Delaware, we are more than thrilled that we're also contributing to the national conversation on ways to improve breast cancer prevention. So with that, I thank you for your attention. I thank you for having me, and I would welcome comments and questions. Thank you.